Hello and welcome to the second section of EMS 453 Ventilator Physiology. In this section we are going to be talking about initial ventilator settings and where we begin. We've just intubated a patient and we want to put them on the mechanical ventilator. So how do we choose what settings we should be using? For this section you will need three different pieces of material that can all be found under this section in Moodle. The first of those is the PDF version of the presentation that has these slides on it as well as space for you to take notes on. The second thing you will need printed out is the initial ventilator settings reference, and that's just kind of a quick summary of what initial ventilator settings you're going to use that we'll be talking about in this section. And then lastly, you will need to print out the initial ventilator settings practice sheets, and we will be using those throughout this presentation as well. So once you have all of those printed out and ready to go, you can move on and we'll get started with this section. So the first thing we need to talk about is initiating versus continuing mechanical ventilation. So for interfacility transports, meaning you're taking a patient out of one hospital to another hospital. Maybe they're in the emergency room at a small rural hospital and you're taking them to the ICU at a bigger hospital. So for those interfacility transports, if the patient is already on mechanical ventilation at the sending facility, it's okay to continue to use the settings on the sending facility's ventilator, but only if they are appropriate and effective. So nothing wrong with using the settings that they have, but you must ensure that they are effective for the patient and that they're appropriate. So what we're going to focus on in this section is more the primary initiation of mechanical ventilation, meaning choosing the appropriate settings to start a patient on, but also you're going to need to know this stuff to be able to check the appropriateness of settings that have been previously initiated. So what you learn here is also going to help you figure out if you go to that hospital to pick up a patient to take him to a different hospital, the patient's already on a ventilator. The stuff we talk about here is going to help you make the decision as to whether the settings that hospital has the patient on are appropriate or not. So no matter the settings you use, though, you should always trial the patient on your transport ventilator for at least a few minutes prior to departing the sending facility to ensure that the patient is tolerating those settings. So just because they're on a certain set of settings on the hospital's ventilator, even if you dial those exact settings into your transport ventilator, not all ventilators are the same. They don't all provide breaths the same way. So you must stay at the bedside and trial your patient on your transport ventilator, like I said, for at least a few minutes to make sure that the patient's going to tolerate that. You don't want to be out the door in your ambulance and on your way when you realize that, oh no, that this is not going to work. So that is extremely important. So the first setting that we'll talk about when it comes to initiating mechanical ventilation, the first thing that you're going to have to choose when you turn that ventilator on is the breath type. So we have two different breath types that we can use. The first is volume control, abbreviated VC. And in volume control, a breath is delivered until a specified volume is reached. Okay. The second breath type that we can choose to use is pressure control, and that's abbreviated PC. In pressure control, a breath is delivered until a specified pressure is reached. So we're going to talk about each of these in much more detail in the following slides. So the first breath type that we're going to talk about is volume control, abbreviated VC again. In volume control, air is going to be delivered through the circuit to the patient until a determined volume is met. So that volume is something that we choose as well. That's the tidal volume, or the VT in milliliters. So in volume control, the ventilator is going to blow air through the circuit to the patient until it measures that it has blown in whatever tidal volume we set. So an advantage of this is that it allows us to control the patient's minute ventilation very tightly. If we know the patient is going to receive this exact tidal volume with every breath, that allows us to maintain really tight control of their minute ventilation. Now, a downfall of this breath type is that the pressure that the lungs feel is going to vary breath to breath based on the resistance of the patient's airways and the compliance of their alveoli. And by compliance, we mean how stretchy their alveoli are. Because we're blowing in the same amount of air with every breath, no matter what, the ventilator is going to do it. The pressure the lungs feel every breath, it's going to be different just based on that airway resistance and alveolar compliance. If the lungs can't stretch well, if they're very non-compliant, if the airway has a lot of resistance in it due to bronchoconstriction or secretions or inflammation, then all that tidal volume that you're blowing in is going to create really high pressures because no matter what, it's going in. So this breath type works well as long as the lungs are compliant, as long as they can expand, as long as they're not injured. They are able to take that tidal volume and it works well. But if they are stiff, injured lungs, then volume controlled breath type is not ideal. It's also not ideal for pediatric patients, and especially those that are less than 10 kilograms, because their lungs are so small and fragile that just blowing in a set tidal volume without paying attention to how much pressure that's causing in the lungs, that can cause damage to their little fragile lungs. Now, our second main breath type that we can choose to use is pressure control, abbreviated PC again. So in pressure control, the ventilator is going to deliver air through the circuit until a determined pressure is met. Now, that pressure is something we choose. We set a pressure control in centimeters of water. So it gets kind of confusing here because the name of the breath type is pressure control. You can select that breath type. But also, if you do select this breath type, you have to select a number. You have to select the pressure that ventilator is going to blow air until it meets. So that number is also called the pressure control. It's measured in centimeters of water. In this breath type, in pressure control breath type, the ventilator will provide high flow at the beginning of inspiration and then decrease to a decelerating flow as the pressure in the lungs rises. So decelerating flow results in laminar airflow, and that potentially creates more even distribution of ventilation. So not something you need to know, but just something that I wanted to include in there with how this breath type delivers the breath. So something that is different with this breath type than in volume control is that the tidal volume that is received by the lungs in pressure control breath type is going to vary breath to breath based on airway resistance and alveolar compliance. So let's compare this to pressure control breath. Let's compare this to volume control breath type. In volume control, the ventilator is going to blow in a set tidal volume no matter what with every breath. Now, with that, we said that the pressure that the lungs feel every breath is going to be different based on airway resistance and alveolar compliance. Now, in pressure control breath type, the pressure is going to be the same breath to breath because we set it. We set that pressure control number, and so the ventilator is going to blow air in until that pressure is met every breath. What is going to change breath to breath, though, is the tidal volume. Because if the airway resistance is really high and the alveolar compliance is very poor, the ventilator is going to blow air in, and it's going to reach that high pressure very quickly. Therefore, you're not going to be able to blow much air into those lungs. So the tidal volume, breath to breath, will change in pressure control breath type. The pressure that the lungs feel is going to stay the same, breath to breath, but the tidal volume changes breath to breath. So this breath type works well with lungs that are small, stiff, non-compliant, or injured, because it allows us to avoid barotrauma. And barotrauma just means damage to the lungs due to high pressures. So in these lungs that are small, stiff, non-compliant, injured, the last thing we want to do is create high pressures that's going to make that worse. And so if we set the pressure that we want the ventilator to blow air into until it meets, then we can control that pressure. But what we don't control is the tidal volume, breath to breath. This breath type can be used for any patient population, but it should always be used in pediatrics less than 10 kilograms because of their small, fragile lungs. So we talked about breath type. Now the next setting that you're going to need to input on the ventilator when you're initiating mechanical ventilation is the mode. So we have three main modes that we're going to talk about that are fairly universal across most ventilators. The first mode is continuous mandatory ventilation, abbreviated CMV. The second is assist control, or AC. And the third is synchronized intermittent mandatory ventilation, or SIMV. And we're going to talk about all these in detail on the following slides. So our first mode is CMV, again, continuous mandatory ventilation. In this mode, you are going to set the respiratory rate, and then you're going to set either the tidal volume or the pressure control, like we talked about on the previous slides, depending on the breath type. The patient is going to get no more and no less than what is set. So if you set a respiratory rate of 15 and a tidal volume of 400 milliliters, that ventilator is going to give that patient 15 breaths of 400 milliliters every minute, no matter what, up and down, no matter what's happening. So that works okay in a setting like the operating room, where the patient is paralyzed and completely sedated and not trying to breathe at all on their own. But in our environment, this mode creates issues with synchrony and compliance. So it's not a good option for us to use in the transport and pre-hospital environment, because if the patient wants to get more breaths and is trying to breathe over the ventilator will not allow that, and so that the patient just won't be compliant with the ventilator. So our second mode is assist control, or AC. Just like in CMV, in AC we are going to set a respiratory rate and then either a tidal volume or a pressure control, depending on whatever our breath type is that we've chosen. Now the patient is going to get at least what is set. So the patient is going to get that set tidal volume or pressure control for the set respiratory rate. So they're definitely going to get, if you set a respiratory rate of 15 and a tidal volume of 400, they're definitely going to get 400 milliliters 15 times a minute. Now, any additional patient effort, so if the patient tries to breathe 17 times a minute, so above the respiratory rate that we set, they're going to get the full tidal volume or pressure control for anything above that they try to initiate. So therefore the patient can get more, but no less than what is set. So again, if you set a respiratory rate of 15 and a tidal volume of 400, and the patient breathes 18 times a minute, those 3 extra breaths a minute, they're going to get the full 400 milliliters of tidal volume. So issues that this mode can create include issues with overbreathing. So if the patient is very tachypnic, they're breathing at a very fast rate, every time they breathe, they're going to get that full tidal volume. So that's going to create an extremely high minute ventilation. If they're breathing 30 times a minute and you've got them set on a tidal volume of 400, they're going to get 400 milliliters 30 times a minute. And so that can cause massive overventilation in our patients. It can also cause breath stacking. And when I talk about breath stacking, we're talking about the ventilator tries to start another breath before the previous breath has been fully exhaled. So again, if the patient is very tachypnic, they don't have time to exhale the last breath before the ventilator tries to shove in another 400 milliliter tidal volume. Also issues with auto-triggering. And so auto-triggering basically means the ventilator is, for some reason, triggering itself to give a breath instead of the patient triggering it to give a breath. That can be caused by vibration, which obviously in our environment there's a lot of as we bounce up and down the road in the back of the ambulance. So the ventilator is basically feeling that vibration, and it thinks that that is the patient trying to take a breath. So it'll give the patient the full tidal volume again, where in fact the patient wasn't trying to take a breath. So there is a better mode we can use for our environment, and that'll be on the next slide. So the mode that we really want to focus on and use in the pre-hospital and transport environment is SIMV, or Synchronized Intermittent Mandatory Ventilation. So in this mode, just like in CMV and AC, we are going to set a respiratory rate, and we're going to set a tidal volume or pressure control depending on what our breath type is. But in SIMV, we're also going to set a pressure support, or a PS abbreviated. So the way this mode works is that the patient is going to get at least what is set. They're going to get the set tidal volume or pressure control for the set respiratory rate. But the ventilator is going to give these breaths that we set in synchrony with the patient's spontaneous respirations. So this is kind of a smart mode. So if we set a respiratory rate of 15 and a tidal volume of 400, the patient is definitely going to get at least 15 breaths of 400 milliliters every minute. But the ventilator is going to try to synchronize those breaths with the patient's spontaneous respirations. Then, if the patient tries to breathe above this, so if they try to breathe 17 or 18 times a minute above the respiratory rate that we set, that additional patient effort is only going to receive the pressure support that we set. It's not going to receive the full tidal volume or the full pressure control. So this pressure support is basically just less support for the patient than the full tidal volume or pressure control. Now, that it's important that they're getting some support on those extra breaths, because that is going to compensate for breathing through the endotracheal tube, which is like breathing through a straw. So if we don't give them that support, it makes their work of breathing very difficult. So the pressure support really compensates for breathing through the endotracheal tube and decreases work of breathing. But it still requires the patient to use their normal muscles of inhalation. So there's still any extra breaths above those that we set, the patient is having to do that work on their own with just a little help from the ventilator to compensate for that, the ET tube, and decrease the work of breathing. So the first breath in a breath interval in this mode is going to trigger the ventilator to deliver the full set tidal volume or pressure control, just like an AC breath. But subsequent breath attempts by the patient in the same breath interval will not have the set tidal volume or pressure control delivered. Rather, it's going to allow the patient to inspire to the magnitude that their lungs can draw with the assistance of the pressure support. So that was just basically a different way of saying the same thing. Now, this mode is ideal, like I said, for the transport environment because it allows for improved compliance and less risk of breath stacking, and that's because it's synchronizing these breaths with the patient's spontaneous respirations. So the patient will be much more compliant with the ventilator and won't have that risk of breath stacking. There's also much less a reduced risk of negative effects like the high minute ventilation and overventilating if the patient is tachypnic and overbreathing the set respiratory rate, or if the ventilator is auto-triggering, because any extra breaths above what we set is not getting the full tidal volume or pressure control. It's only getting that little extra help of the pressure support. So there's not near as high of a risk of overventilating the patient if they're tachypnic, or if the ventilator starts to auto-trigger, it's not going to give them these huge extra tidal volume breaths that results in way too high minute ventilations. Now we're going to put together the breath type and the mode, and kind of learn the lingo of ventilator settings here. So when you hear somebody talk about kind of the overall settings that the ventilator is in at any given time, usually they combine the breath type and the mode. So they'll say the patient's in VCAC, meaning the breath type is volume control, the mode is assist control. Or they're in PCSIMV, so the breath type is pressure control, the mode is synchronized intermittent mandatory ventilation. So what I want you to do is pause the video here, and I'm not going to talk through each of these, but I want you to think about and explain to yourself what each of these, what the ventilator is doing with each of these settings. So in VC-CMV, VC-AC, VC-SIMV, PC-CMV, PC-AC, and PC-SIMV. If you can tell yourself how the ventilator is acting in each of these 6 settings, then you're doing really well. So if you're confused for that, rewind the video, go back and look at each of those breath types and modes, and try to figure out what the ventilator is doing in each of those. So now we're going to get into talking about some numbers and settings that we have to input into the ventilator that require some math. So we're going to start out by talking about the size of patients' lungs. Now, you've got a sumo wrestler who weighs 400 pounds and is 5 foot 8 inches tall. And you've got a bodybuilder who weighs 250 pounds and is also 5 foot 8 inches tall. So their weights are very different. Whose lungs do you think are bigger? So the answer to that is that if they're both 5 foot 8 inches tall, their lungs are going to be essentially the same size. So the size of the patient's lungs is not dictated by how much the patient weighs. The size of the patient's lungs is more determined by how tall they are, and that's the main thing. There's a few other things that go into it and that we'll talk about, but the main thing to know is that size of the lungs does not correlate with weight. It correlates with height. So that is why we have to talk about ideal body weight. Basically, ideal body weight, all it's telling us is for a patient's height, ideally, what would their body weight be? Doesn't matter what it actually is. They may be less than that, or they may be more than that, but ideally, for a given height, what should their weight be? Now, ideal body weight is based on the patient's age, like I said, height, and their sex. Ideal body weight is always reported in kilograms. So you must know how to convert from pounds to kilograms, and that is the patient's weight in the pounds divided by 2.2 equals kilograms. But when we're talking about ideal body weight, we're always talking about kilograms. So, for adult males, this is very important. To calculate the adult male's ideal body weight, you're going to take 2.3 kilograms multiplied by the number of inches over 60 inches that the patient is. 60 inches is also 5 feet. So 2.3 kilograms multiplied by inches over 5 feet. Then you're going to add that to 50 kilograms. Okay. For adult females, it's almost the same, just a slight difference. You're going to take 2.3 kilograms multiplied by inches over 60, or inches over 5 feet, and then add that to 45.5 kilograms. Now, if the patient is under 5 feet and they're an adult, then you're going to subtract 2.3 kilograms times the inches under 60 that they are, or under 5 foot. You're going to subtract that from 50 kilograms for males, or 45.5 kilograms for females. We don't have to worry about that too often. Most of the vast majority of adults that we take care of are going to be greater than 5 feet tall. But should they not be, then we're going to take 2.3 times the inches less than 60 that they are, and then subtract that for 50 kilograms if they're a male, or 45.5 kilograms if they're a female. Okay, so that's adults. Now for pediatrics, regardless of male or female, all pediatrics, we're going to calculate their ideal body weight by taking their years of age multiplied by 2 and then adding 8. Okay, and as a reminder, pediatrics are anybody from 1 year of age up to 5 foot, or up to puberty, whichever comes first. Okay, infants, to calculate their ideal body weight is real easy. We're not going to use ideal body weight. We're going to use their actual body weight, also abbreviated ABW. So ideal body weight is IBW. You'll see that from now on in the presentation. That's what that means. ABW is actual body weight. So if you respond to an infant and you don't know their weight, then we may need to estimate it using a Broslow tape, the hand Tevi system, etc. whatever system your service uses for that. But regardless, we're not calculating an ideal body weight for them. We're going to use their actual body weight if known, or estimated using a Broslow tape or hand Tevi or something similar. So now we are going to practice calculating different patients' ideal body weight. So for this part, you are going to need your initial ventilator settings practice sheets. That first sheet that you should have there should have, I believe, 8 different patients on it, numbered 1 through 8. And so we're going to work through all of those settings, but first we're going to start out with each patient's ideal body weight. And we'll do those one at a time. So our first patient is a 6 foot 0 inch 50-year-old male who is post cardiac arrest. So go ahead and pause your video here, calculate that patient's ideal body weight, and then you may resume the video and we'll check your answer. So the ideal body weight for this patient is going to be 77.6 kilograms. And we got that by taking 2.3, this is an adult male, times inches over 5 feet. So this patient is 6 feet tall, so that's 12 inches over 5 feet. So 2.3 times 12 equals 27.6. Then we're going to add that to 50, giving us 77.6 kilograms. Our second patient is a 5 foot 7 inch 81-year-old female with a CHF exacerbation. So pause your video and calculate this patient's ideal body weight. So this patient's ideal body weight is 61.6 kilos. Now we got that by taking 2.3 times 7, because she's 5 foot 7 inches, and then adding that to 45.5, because she is an adult female, 61.6 kilograms. Patient number 3 is a 7-month-old, 17.6 pound female with a foreign body aspiration. So pause your video and calculate this patient's ideal body weight. So this is kind of a trick question. This patient's ideal body weight is going to be their actual body weight. So because it's an infant, we're going to use actual body weight instead of calculating an ideal body weight. Now, this patient's actual body weight was given to us in pounds. So we talked about how ideal body weight is always reported in kilograms. So we need to convert how their weight in pounds to kilograms. And 17.6 divided by 2.2 is going to give us 8 kilograms. Patient number 4 is a 4 foot 6 inch 7-year-old male with an asthma exacerbation. So pause your video, calculate this patient's ideal body weight. So this patient's ideal body weight is going to be 22 kilograms, and we got that by taking 7, because he's 7 years old, times 2 plus 8. That gives us 22 kilograms. Patient number 5 is a 5 foot 5 inch 16-year-old male with pneumonia. So pause your video, calculate the ideal body weight for this patient. This patient's ideal body weight is 61.5 kilograms. Now, 16-year-old, you may be thinking that this patient is a pediatric, but like we said, for ventilator settings, anybody over 5 foot or past puberty is going to be considered an adult, and this patient obviously is taller than 5 foot, so we're going to use the adult male calculation, which we would take 5 times 2.3 and then add that to 50, giving us 61.5 kilograms. Patient number 6 is a 6 foot 2 inch 75-year-old female with a COPD exacerbation. So pause your video and calculate the ideal body weight for this patient. So this patient's ideal body weight is going to be 77.7 kilograms, and we get that by taking 2.3 times 14, and 14, that's because 6 foot 2 inches is 14 inches taller than 5 foot. And then we're going to add that to 45.5 because she is an adult female. That gives us 77.7 kilograms. Patient number 7 is a 4-month-old, 13.2 pound female with status epilepticus. Go ahead and pause your video and calculate this patient's ideal body weight. So hopefully you weren't confused by this one now. Again, 4 months old, this patient is an infant, so we're going to use her actual body weight. It tells us how much she weighs in pounds. And so if we take 13.2 divided by 2.2, it gives us an actual body weight of 6 kilograms. So that's what we will use. And then lastly, we have a 3 foot 2 inch 4-year-old victim of near drowning. So pause your video and calculate this patient's ideal body weight. So this patient's ideal body weight is going to be 16 kilograms. This is a 4-year-old pediatric patient, and so we're going to take 4 times 2 and then add 8 to that, giving us 16 kilograms. Alright, so hopefully you got the hang of calculating ideal body weight. If not, feel free to practice some more until you get that down, because this is going to be very important as we move on. So now we're going to talk about tidal volume and how we actually pick a number to input into the ventilator for a tidal volume. We already talked about in the first section what effects we expect to see if we increase the tidal volume or decrease the tidal volume, and how that should affect the patient's ventilation and end-tidal CO2. But now we need to know where do we start? What number do we put in the ventilator? So tidal volume is only a setting in volume control breath type. That means you're only going to input a number for tidal volume into the ventilator if you've picked volume control breath type. But we still need to calculate a tidal volume for both volume control and pressure control breath types. And we'll talk more about why we need a tidal volume calculated for pressure control later. But for now, just know that it doesn't matter whether you're using volume control or pressure control. Both of them require you to calculate a tidal volume for the patient. Now, expected tidal volume, like we said earlier, for a normal patient of any age is 6 to 8 milliliters per kilogram of ideal body weight. But for initial settings, we're going to say start with 6 milliliters per kilogram of ideal body weight. That's on the high end of what we consider lung protective ventilation. And lung protective ventilation is what we're going to use for any patient who we suspect has any type of lung injury. So their lungs are already injured, damaged, stiff, non-compliant, whatever it may be. We don't want to make it any worse. And like we talked about earlier, we make it worse by causing too high of pressures in the lungs, barotrauma, like we mentioned earlier. So if that's the case, we want to use lung protective ventilation, and that is considered 4 to 6 milliliters per kilogram of ideal body weight. So we're going to start with 6. That's going to be birth to earth, meaning all ages. Now, the exception to this is in patients with obstructive pathophysiology. And when we talk about obstructive pathophysiology, what we're talking about is patients with any disease process going on in their lungs that causes an obstruction to airflow. The main patients we're going to see that have this going on are COPD patients and asthma patients. Both, and we're not just talking about they may have COPD or they have had asthma before. We're talking about somebody who is currently the reason for their respiratory inadequacy is either a COPD exacerbation or an asthma exacerbation. So in these patients, we can start with a higher tidal volume. And by higher, we mean 7 to 8 milliliters per kilogram of ideal body weight. Now, we'll talk about why this is later and why it works. These patients tolerate a higher tidal volume later. But for now, just know we're going to use 8 milliliters per kilogram of ideal body weight for obstructive patients in our scenarios. So it's rarely necessary to set a tidal volume greater than 8 mils per kilogram of ideal body weight. And so there's just I can't really think of a situation where that would be necessary in the normal circumstances that we see. So things to know here: for the vast majority of patients, we're going to start with a tidal volume of 6 milliliters per kilogram of ideal body weight. For our obstructive pathophysiology patients, we're going to start with a tidal volume of 8 milliliters per kilogram of ideal body weight. So now we're going to do some practice calculating initial tidal volumes for our patients. For this, you're going to need your initial ventilator settings practice sheet that we used earlier to calculate the ideal body weights. And we're going to go through the same 8 patients and use their ideal body weight that we calculated earlier to determine what their initial tidal volume should be. So our first patient is our 50-year-old male post-cardiac arrest. So go ahead and pause the video here and calculate what his initial tidal volume should be. So you should have gotten a tidal volume of 466 milliliters, and we would get that by multiplying his ideal body weight from earlier by 6 milliliters per kilogram, and that should give us 466 milliliters. Patient number 2 is our 81-year-old female with a CHF exacerbation. So pause the video and calculate her initial tidal volume. And for this patient, you should have gotten a tidal volume of 370 milliliters, again, by multiplying her ideal body weight by 6 milliliters per kilogram. Patient number 3 is our 7-month-old female with a foreign body aspiration. So pause the video and calculate her calculate her tidal volume. And for this patient, you should have gotten a tidal volume of 48 milliliters by taking her ideal body weight of 8 kilograms by multiplying that by 6 milliliters per kilogram, giving us 48 milliliters. Patient number 4 is our 7-year-old male with an asthma exacerbation. So pause the video here and calculate his initial tidal volume. And this is our first patient with obstructive pathophysiology. So like we talked about earlier, an asthma exacerbation is one of those that falls under the category of obstructive pathophysiology. So we are going to use an initial tidal volume of 8 milliliters per kilogram instead of 6 milliliters per kilogram. So multiplying his ideal body weight by 8 milliliters per kilogram should have given you a tidal volume of 176 milliliters. Now, patient number 5 is our 16-year-old male with pneumonia. So pause the video and calculate his ideal body weight. Now this one may have been a little tricky because when you think of 16-year-old, you might think of a pediatric, but remember, anybody that is greater than puberty or taller than 5 foot, which this patient is, we're going to treat them as an adult. So we use their ideal body weight from earlier, multiply it by 6 milliliters per kilogram, giving us 369 milliliters for a tidal volume. Patient number 6 is our 75-year-old female with a COPD exacerbation. So pause the video and calculate her initial tidal volume. And you should have gotten a tidal volume of 622 milliliters. So again, COPD exacerbation falls under that obstructive pathophysiology, so we're going to use a tidal volume of 8 milliliters per kilogram. If we multiply 8 by her ideal body weight, that gives us 622 milliliters for her tidal volume. Patient number 7 is our 4-month-old female with status epilepticus. So pause the video and calculate her initial tidal volume. And you should have gotten a tidal volume of 36 milliliters by multiplying her ideal body weight by 6 milliliters per kilogram. And lastly, we have our patient number 8, our 4-year-old male near drowning patient. So pause the video and calculate his initial tidal volume. And you should have gotten a tidal volume of 96 milliliters for this patient by multiplying, again, his ideal body weight by 6 milliliters per kilogram. So the next setting we're going to talk about is the pressure control. We abbreviate that PC, and I'm sure you're thinking, well, we already talked about pressure control, and you're right, we did. We talked about the pressure control breath type. And so if we choose that breath type, we also have to dial into the ventilator an actual pressure control number, or a numerical value that is a unit of pressure. So we're only going to set a pressure control if we're in pressure control breath type. If we're in volume control breath type, then we don't have to worry about setting a pressure control number at all. But if we're in pressure control breath type, we have to set a pressure control number, and for all of our patients, we're going to start out with a pressure control of 15 centimeters of water. So you might remember back when we were talking about the pressure control breath type, we said that the tidal volume, so the amount of air that the patient is going to receive from the ventilator when we're in pressure control breath type, is with that set pressure control that you set, is going to be variable breath to breath. So, and that is going to be based on the compliance of those alveoli and the resistance of the airways, and it's going to vary patient to patient. So we know that the tidal volume that the patient's going to receive with whatever the set pressure control is that you input is going to be variable breath to breath. But the ventilator will measure that tidal volume for us. So even though we're not setting a tidal volume, we're setting a pressure control value, the ventilator is going to measure the tidal volume that the patient is receiving with that given pressure control that we inputted. So this kind of goes back to when we talked about tidal volume and why even if we're not in volume control breath type, we still have to calculate a tidal volume for our patients. So no matter what, whether we're in volume control breath type or pressure control breath type, we're always going to calculate a tidal volume. Now if we are in volume control breath type, we're going to use that tidal volume and dial it into the ventilator, right? But if we're in pressure control, we're not. We're going to dial in our pressure control value. That's our 15 centimeters of water. So, why do we have to still calculate a tidal volume? Well, we have to still calculate a tidal volume because we need to know with our set pressure control that we're providing, are we giving the patient enough tidal volume? So in volume control, we call our tidal volume the actual tidal volume because we're going to actually dial that into the ventilator and the patient will get that amount. In pressure control, that tidal volume that we calculated, we're going to call that our targeted tidal volume. So that's our goal, is for us to hit that tidal volume. Now, like I said, the ventilator will measure the tidal volume that the patient's actually receiving with the set pressure control that we inputted, and that's going to be the reading that it's going to give us is called a VTE, and we'll talk a lot more about that in section 3. But for right now, just know that the ventilator does measure the tidal volume that the patient's receiving in pressure control breath type, and it gives it to us as a VTE. And we have to monitor that VTE to make sure that our patient's getting the appropriate tidal volume. So basically, we're making sure that we're meeting our targeted tidal volume that we calculated for the patient. Now, if we're not, no worries. We can adjust that pressure control up or down by 1 to 2 centimeters of water at a time until we achieve that targeted tidal volume that we calculated that our patient needs. So if we need to increase our tidal volume, we're going to increase our pressure control number. And that makes sense because if we increase that pressure control number, we're telling the ventilator that it needs to meet a higher pressure. So to do that, it's going to blow more air in. And blowing more air in just means that the patient's getting a larger tidal volume. It's going to keep blowing air in until it meets that higher pressure, and that's going to result in a higher tidal volume. Now, if our patient's on 15 centimeters of water pressure control, and that they're getting too high of a tidal volume, it's over what we were targeting, then we can decrease that pressure control number. And the ventilator's going to, we're basically telling the ventilator, hey, stop blowing air in at a lower pressure. And so it's going to meet that target pressure quicker. That'll take less air to meet, and therefore the tidal volume will be less. Now, this is really key to understand. The difference between the pressure control that you set and the PEEP that you set is what actually increases the tidal volume and therefore affects ventilation. So it's not just the pressure control in isolation that is going to affect that tidal volume and therefore the ventilation. It's the difference between the pressure control and PEEP, because the pressure control is going to be that pressure in the lungs at when the patient's inhaling, at the very top of inhalation. And then the PEEP is the pressure in the lungs at the very bottom of exhalation. So the difference between those two, the top of inhalation and the bottom of exhalation, what happens between there is the tidal volume. And so if we have a bigger difference between those two numbers, that's going to create a bigger tidal volume. If we have a smaller difference between those two numbers, it's going to create a smaller tidal volume and therefore decreased ventilation. So bigger tidal volume, increased ventilation; smaller tidal volume, decreased ventilation. So just as an example here, we'll say that we set our patient on 15 centimeters of water for their pressure control and 5 centimeters of water for their PEEP. So the difference between those two numbers is 10. Okay, so that 10 centimeters of water is going to create a certain tidal volume. Now it's going to vary, obviously, patient to patient, vary breath to breath, depending on that alveolar compliance and airway resistance and things like that. But if we take that same patient and we increase their pressure control to 20 and we leave their PEEP at 5, now the difference between our two numbers is 15. So that's going to create a larger tidal volume. There's a larger difference between the two numbers, and so we're going to get increased ventilation. But say instead of leaving our PEEP at 5, say we also increased our PEEP to 10 in addition to increasing our pressure control to 20. Okay, so now the difference between those two numbers is 10. Well, that's what it started out as. Our numbers before were 5 and 15 with a difference of 10. Now they're 10 and 20, still a difference of 10. So the tidal volume that we're going to get is going to be about identical, because even though we increase the pressure control, because we also increase the PEEP, the difference between those two numbers stays the same, and so we're not going to get an increased tidal volume, and therefore our ventilation is not really going to be affected. Okay, so now we're going to talk about respiratory rate and how we determine what respiratory rate we should set on the ventilator. Now, we're going to have to go back and remember minute ventilation. We talked about minute ventilation in section 1 of the course. And so let's just review that a little bit. Minute ventilation, if you remember, is the tidal volume multiplied by the respiratory rate. Okay, so for most adult patients, our target minute ventilation is going to be 100 milliliters per kilogram per minute of ideal body weight. For our pediatrics, that's going to increase to 150 milliliters per kilogram per minute. And then for our infants, 200 milliliters per kilogram per minute. Okay, so what we can do with this is kind of rearrange that equation, that equation minute ventilation equals tidal volume times respiratory rate. If we rearrange that, we can say that respiratory rate is going to equal minute ventilation divided by our tidal volume. Now remember, we already figured out our targeted tidal volume, and we know how to find our minute ventilation. So if we have those two pieces of information, we can take our minute ventilation divided by our tidal volume and come up with our respiratory rate. So step 1 is going to be to calculate that targeted minute ventilation. For the adult, again, we're going to take 100 milliliters times the patient's ideal body weight in kilograms. That's going to give us our targeted minute ventilation. So then step 2 is to find the respiratory rate by dividing that minute ventilation, that targeted minute ventilation, by that tidal volume that we already calculated. So minute ventilation divided by tidal volume is going to give us our respiratory rate. Now, when we talk about minute ventilation, we can use two different kind of representations that you'll see over here on the slide. Let's talk about the one on the far right first. This is kind of a thing to help you visualize how this equation is going to work. So what you do here is you cover up the variable that you want to know. So if I want to know the minute ventilation, if I cover that up, what I'm left with is tidal volume and respiratory rate. They're next to each other, so I'm going to multiply them together. And that makes sense. We know that the minute ventilation equals tidal volume times respiratory rate. Now, if I want to know the respiratory rate, which, in this case, that's what we're working on, I'm going to cover up respiratory rate, and now I have minute ventilation that is on top of tidal volume. So that means we're going to take minute ventilation divided by tidal volume to give us our respiratory rate. Okay, so that's just kind of hopefully a helpful visual representation of how this works. Now let's talk about the VE pi. So VE pi is another visual representation. Now the whole circle, the entire pi, is our minute ventilation. And we know that minute ventilation is made up of two pieces, tidal volume and respiratory rate. If you take away from one, either the tidal volume or the respiratory rate, you must add to the other, either the tidal volume or respiratory rate. We can never have less than a whole pi because we have to meet the patient's demands and the patient's needs for minute ventilation. That's critically important. So for an adult, we have to meet that 100 milliliters per kilogram per minute that they need. That means we can never have an empty piece of pie. But what we can do, if we need to, and we'll talk about why we would do this later, is we can adjust either the tidal volume or the respiratory rate for different reasons that we may do that. But if we do that, we must add to one if we're taking away from the other, or take away from one if we're adding to the other, because we always have to have 100%. We always have to have a full pie. So kind of what does this mean for our different patient populations and their disease processes? So our lung injured patient that we talked about, this means that they're going to have a higher respiratory rate. They have the same minute ventilation demand, right? But they're going to have that lower tidal volume. Remember, the lung injured patient is going to have the tidal volume of 6 milliliters per kilogram of ideal body weight. So that means if they have a lower tidal volume, they're going to have a higher respiratory rate, so that we still have 100% of our VE pi. Now, if we look at our obstructive pathophysiology patient, remember their tidal volume, we're going to start with a higher tidal volume for them. They get the 8 milliliters per kilogram of ideal body weight. Therefore, we're going to start them on a lower respiratory rate. They have the same minute ventilation demand, but since we're starting them on a higher tidal volume, we have to start them on a lower respiratory rate to keep our VE pi as a 100% full pi. So now let's go ahead and do some practice with our 8 practice patients. We're going to practice calculating their VE and respiratory rate. So go ahead and get your initial ventilator settings practice sheet back out. And we'll start with patient number 1. So this is our 50-year-old male post-cardiac arrest. Go ahead and pause your video and use the ideal body weight that we've already calculated for this patient, as well as the tidal volume that we've already calculated for this patient, to figure out A, what his targeted minute ventilation should be, and then B, what his respiratory rate is going to be to start with. And for this patient, you should have gotten a targeted minute ventilation of 7,760 milliliters per minute. But remember, we report minute ventilations in liters per minute. So if we divide that by 1,000, we get 7.76 liters per minute. And the way we got that value is by taking his ideal body weight multiplied by 100. He's an adult, so we're going to use the 100 value for his minute ventilation target. Alright, and then for his respiratory rate, you should have gotten a respiratory rate of 17. And the way we get that is by taking that 7,760 milliliters per minute number, dividing that by the tidal volume that we already calculated for him, and that is going to give us a respiratory rate of 17 breaths per minute. Alright, patient number 2, our 81-year-old female with a CHF exacerbation. So go ahead and pause your video and calculate her targeted minute ventilation and initial respiratory rate. So for this patient, you should have gotten a minute ventilation of 6,160 milliliters per minute, or 6.16 liters per minute, again by taking her ideal body weight multiplied by 100. And then for respiratory rate, you should have also gotten 17 by taking 6,160 milliliters per minute divided by the tidal volume that we already calculated for her, and giving us 17. Patient number 3, our 7-month-old female with a foreign body aspiration. Go ahead and pause your video and calculate her minute ventilation and respiratory rate. So for this patient's minute ventilation, you should have gotten 1,600 milliliters per minute, or 1.6 liters per minute. Now remember, this is an infant, so we're going to multiply her ideal body weight by 200 to get her targeted minute ventilation. And then for her respiratory rate, we would take that 1,600 milliliters per minute divided by the tidal volume that we already calculated for her, giving us 33 breaths per minute. Patient number 4, our 7-year-old male with an asthma exacerbation. Go ahead and pause the video and calculate his minute ventilation and respiratory rate. So for this patient's minute ventilation, you should have gotten 3,300 milliliters per minute, or 3.3 liters per minute. This is a pediatric patient, so the way we got this value was by multiplying his ideal body weight by 150. And that gives us 3,300 milliliters per minute. For his respiratory rate, we're just going to take that 3,300 milliliters per minute divided by the tidal volume that we already calculated for him, giving us a respiratory rate of 19 breaths per minute. So continuing on with patient number 5, this is going to be our 16-year-old male with pneumonia. Go ahead and pause your video and calculate his minute ventilation and respiratory rate. This patient needs a minute ventilation of 6,150 milliliters per minute, or 6.15 liters per minute. Now remember, 16-year-old, we're going to treat him. He's more than 5 foot tall, and he's post-puberty, so we're going to treat him like an adult. So we're going to take 100 milliliters multiplied by his ideal body weight, giving us that 6,150. And then for his respiratory rate, 6,150 divided by the tidal volume that we calculated for him gives us 17 breaths per minute. Patient number 6 is our 75-year-old female with a COPD exacerbation. So pause your video and calculate her minute ventilation and respiratory rate. So for this patient, you should have gotten a minute ventilation of 7,770 milliliters per minute, or 7.77 liters per minute, by multiplying her ideal body weight by 100. And then if we divide 7,770 by that tidal volume that we calculated for her, that's going to give us a respiratory rate of 12. So this is a good example of the patient with a COPD exacerbation, so obstructive pathophysiology. We talked about a couple slides ago how those patients are going to have a higher tidal volume, but we're going to set their respiratory rate lower to begin with, but still maintain the same minute ventilation. So patient number 7 is our 4-month-old female with status epilepticus. So go ahead and pause the video and calculate her minute ventilation and respiratory rate. And this patient is going to require a minute ventilation of 1,200 milliliters per minute, or 1.2 liters per minute, by multiplying her ideal body weight or actual body weight. Remember, for infants, we're going to use their actual body weight as their ideal body weight. So we're going to multiply that by 200 to get our 1,200 milliliters per minute. And then for respiratory rate, we divide that 1,200 by her tidal volume that we calculated, giving us a respiratory rate of 33 breaths per minute. And then lastly, we have patient number 8. It's our 4-year-old male near drowning. So pause the video and calculate his minute ventilation and respiratory rate. And you should have gotten a minute ventilation of 2,400 milliliters a minute by multiplying his ideal body weight by 150, and a respiratory rate of 25 by dividing 2,400 by that tidal volume that we already calculated. Now we're going to talk about pressure support. You might remember that's abbreviated PS, and we talked about this several slides ago when we were talking about SIMV mode. So this is probably the easiest setting to remember, and we're only going to set this if we're in SIMV mode. We usually set it at 10 centimeters of water. It can be adjusted, but really that is beyond the scope of this course. So for our purposes, we're going to say that we're just going to always set it at 10 centimeters of water. But just remember, we are only going to set this in SIMV mode. Now our next setting to consider is PEEP, or positive index respiratory pressure. You might remember that intrinsic PEEP, so what you and I are experiencing right now, is between 3 and 5 centimeters of water. So we are always on our ventilator going to start with a minimum PEEP of 5 centimeters of water. So every single patient, every time, you're going to start with a minimum PEEP of 5 centimeters of water. Now, we may have to increase this as needed to improve oxygenation. Remember, PEEP is one of our 2 settings that we can change to improve oxygenation. PEEPs of 10 centimeters of water or higher are commonly required for hypoxic patients with ARDS. So you don't be alarmed if you see PEEPs higher than 5 and often higher than 10 in those types of patients. Now, the maximum PEEP that you're allowed to set is usually directed by your services protocol. You're rarely going to use PEEPs of greater than 15 to 20 centimeters of water in the pre-hospital environment. So you may see higher PEEPs than this in the hospital, but likely you're not going to be using PEEPs higher than 15 to 20 outside of the hospital. Something really important to remember is that increasing the PEEP has other effects on the body aside from increasing oxygenation. And we can relate this to the damage we can do with a bag valve mask, as well as what we have to worry about when we put a patient on CPAP. So remember, with each of those things, the higher pressure we use, whether it be with the BVM or with the CPAP, we're going to increase the patient's intrathoracic pressure. So the pressure inside their chest is going to increase with the higher the PEEP is, or the higher the pressure we use. That's going to result in decreased venous return of blood to the heart. So less blood is going to be able to get back to the heart because of the higher pressure inside the chest. So what does that result in? It results in decreased cardiac output. If less blood is coming back to the heart is going to be pumping less blood out. So decreased cardiac output. And then we're going to see this as hypotension. So decreased cardiac output is going to cause hypotension in our patients. So it's extremely important to remember that you may have to increase PEEPs, and you commonly will, to improve your patient's oxygenation. But you have to be looking for and expect those higher PEEPs to cause decreased cardiac output and possible hypotension in your patient. The next setting we're going to talk about is our FiO2, or fraction of inspired oxygen. On every patient, if we're initiating mechanical ventilation, we're going to start with an FiO2 of 100%, or 1.0. Now we can titrate down that FiO2 by 5 to 10% at a time. Always, we want to maintain our SpO2 between 94 and 99%. There is such a thing as oxygen toxicity, and that becomes a concern if you're receiving a higher than necessary FiO2 for a prolonged time. So short periods of higher FiO2s than necessary is not going to hurt the patient, but for longer periods of time it absolutely will cause oxygen toxicity, and that can cause several issues in the patient. So we do want to, even though we're starting with 100%, we do want to get that titrated down just to maintain our SpO2 of 94 to 99%. So our last main setting that we're going to talk about on the ventilator is our inspiratory time, also known as I time, and our inspiratory to expiratory ratio. We denote that with an I to E, I:E meaning I to E ratio. So this is probably the most difficult concept and setting to wrap your head around what it actually means and what we're doing. So we're going to try to explain it the best we can here and go from there. So I'm actually going to start with talking about the I to E, which is the second main bullet on the slide. So we're going to kind of go backwards here. So the I to E ratio is the ratio of time spent inhaling to the time spent exhaling. So let's use an adult as an example. The normal I to E ratio for an adult is about 1 to 2, meaning that a normal adult takes twice as much time to exhale than they do to inhale. They take twice as much time spent exhaling than inhaling. Okay? So our pediatric patients, a normal I to E ratio for them is between 1 to 3 and 1 to 4. So that means that they are taking 3 to 4 times longer to exhale than it takes them to inhale. And that's just normal for them. Okay? So let's talk about our obstructive pathophysiology patients. Those, remember, our COPD and asthma exacerbation. A normal I to E ratio for them is about 1 to 4 to 1 to 6. So the reason for this being is it gives them longer to exhale, which is what they have a problem doing. Their obstructive pathophysiology, there's some reason that they have obstruction to airflow. And so what their biggest problem is getting air out, is exhaling that breath. And so if we increase the amount of time that they have to exhale, then that helps them. Giving them longer to exhale helps them because they have problems with it. So this is all good. These numbers, these ratios are good, but these are not numbers that we can dial into the ventilator. Most ventilators don't ask us what we want the I to E ratio to be. There's two settings that we can change, though, to affect the I to E. And those settings are the respiratory rate, which we already talked about, and the I time. So now let's go back up to that first bullet and talk about the I time. So this is the actual time spent inspiring or inhaling and measured in seconds. So it is a setting on the ventilator that we can actually change, that we can set to affect the patient's I/E ratio. The normal I time for an adult is somewhere between 0.9 and 1.1 seconds. A pediatric patient is about 0.7 seconds, and then our infants are about 0.4 seconds. Now, those aren't hard and fast numbers. They're just kind of a ballpark number of them. This is about what these patients take to inhale. So these aren't numbers that I care for you to memorize and know. One nice thing about most ventilators is that usually you'll dial in or set the patient's age range. So you'll say, I'm getting ready to ventilate an adult, or I'm going to ventilate a pediatric, or I'm going to ventilate an infant. And when you tell the ventilator that, it will usually default to an I time that's probably fairly appropriate for that patient, just based on their age category. But what you do need to know is these I/E ratios and kind of how we can adjust the I time to change the I/E ratio to match what our patient really needs. So we will do some practice with this, and hopefully it will make more sense then. So now we're going to kind of work through this calculation and how we relate the I time to the I/E ratio. Okay, so let's just use this first section up here at the top of the slide, as it's basically showing you how these equations work in words, and then we'll put some numbers into those in the second part. So this is step one here. There are 60 seconds in a minute, right? And remember we said that respiratory rate also factors into this I/E ratio. The two factors that affect the I/E ratio are the I time and the respiratory rate. So respiratory rate is measured in breaths per minute, right? Per minute. So there are 60 seconds in a minute. So if we take 60 and divide it by our patient's respiratory rate, that is going to tell us the seconds per respiratory cycle. And respiratory cycle meaning inhalation and exhalation together. How long does it take our patients to complete one full cycle of inhalation and exhalation? 60 divided by the respiratory rate. Okay? Now, step two, we are going to take our value from step one, the seconds per respiratory cycle, and we're going to subtract the patient's I time from that. So whatever I time is on the ventilator, we subtract that from the seconds per respiratory cycle. So that's going to give us the expiratory time, also known as the E time. So that makes sense. If our seconds per respiratory cycle included both inhalation and exhalation, and we remove the inhalation piece, the I time, what we're left with is the expiratory piece, the E time. Okay, so now we have an I time and we have an E time. Now, if we divide the E time by the I time, that's going to give us that E value in our I/E ratio. So E time divided by I time is what creates our ratio. It gives us that E. Now the I in I/E is always 1. It's 1 to 2, 1 to 3, 1 to 4, 1 to 6. The I is always 1. And then we know our E from step 3. So now we just plug that in, and we have 1 to whatever our E was. So let's use some numbers to do this. So if we have a respiratory rate of 17, and we have an I time of 1.1 seconds, those are the two settings on our ventilator that we can adjust to affect the I/E ratio. So with those two values, we're going to calculate what this patient's I/E ratio is right now with a respiratory rate of 17 and an I time of 1.1 seconds. So step one, we're going to take our 60 seconds, because 60 seconds in a minute, and divide it by our respiratory rate of 17 breaths per minute. That gives us 3.5 seconds, and that is seconds per respiratory cycle. So it is taking this patient 3.5 seconds to do a full inhalation and a full exhalation. Now if we take 3.5 seconds and we subtract 1.1 seconds, that's our I time, the amount of time it's taking that patient to inhale. What we're left with is 2.4 seconds, so that's the time it's taking that patient to exhale, our E time. Now if we divide our E time, 2.4 seconds, by our I time, 1.1 seconds, we get 2.2. Remember, we always said the I in I to E is 1, and then the E is what we just calculated in step 3. So with these settings on the ventilator, this patient's current I to E ratio is 1 to 2.2. And that's about what we said a normal adult I to E ratio is, about 1 to 2. Now, the nice thing about ventilators is that all that math that we just did on the previous slide, they will do that for us. So what it's important for us to know is what the appropriate I to E ratio is for our patient. Because even though we don't input that number into the ventilator, if we adjust the respiratory rate or adjust the I time, the ventilator will tell us what I to E ratio that's going to result in. So as long as we know what is appropriate for our patient, we can adjust that I time or the respiratory rate until we get to that I to E ratio that our patient needs. So practice for our I to E ratio, you're going to need your initial ventilator settings practice sheet again with our 8 patients on it, and we're going to go through those patients and decide what their initial I to E ratio should be. So patient number 1, our 50-year-old male post-cardiac arrest. Go ahead and pause the video and decide what his I to E ratio should be. And that would be about 1 to 2. This is an adult patient, no obstructive pathophysiology, so we're going to start this patient with an I to E ratio of 1 to 2. Patient number 2, our 81-year-old female with a CHF exacerbation. Go ahead and pause the video and decide what I to E ratio would be appropriate for her. And again, this patient would require an I to E ratio of about 1 to 2 to start with, just a straightforward adult. Patient number 3, our 7-month-old female with a foreign body aspiration. Pause the video and pick her I to E ratio. And for this patient, we're going to say an I to E ratio of about 1 to 4. So we did talk about pediatrics needing an I to E ratio of 1 to 3 to 1 to 4. Since this, obviously this is an infant, so she's on the very low end of that child range. We'll go with 1 to 4 because we do know that as the younger the child, the longer the amount of time they need to exhale, and that's just physiologic normal for children. So for this patient, about 1 to 4 would be appropriate. Patient number 4 is our 7-year-old male with an asthma exacerbation. Go ahead and pause the video and decide what his I to E ratio should be. And for this patient, we could pick an I to E ratio anywhere between 1 to 4 and 1 to 6. So again, it's a pediatric patient, so we know we're going to want an I to E of at least 1 to 4. But this patient also has an asthma exacerbation, so they have that obstructive pathophysiology. They need a longer amount of time to exhale. So 1 to 4 to 1 to 6, we'll give them that. Patient number 5, our 16-year-old male with pneumonia. Go ahead and pause the video and decide what an appropriate IDE time or IDE ratio would be for him. And for this patient, an IDE of anywhere from 1 to 2 to 1 to 3 would be appropriate. He is 16 years old. We're going to treat him mostly like an adult, but again, he is on the younger end of that adult range. So 1 to 2 to 1 to 3 would be appropriate for this patient. Patient number 6 is our 75-year-old female with COPD exacerbation. Go ahead and pause the video and pick an appropriate IDE ratio for her. And again, COPD exacerbation, and this is obstructive pathophysiology. So we're going to use an IDE ratio of 1 to 4 to 1 to 6 to give her adequate time to exhale. Patient number 7, our 4-month-old with status epilepticus female. Go ahead and pause the video and decide what an appropriate IDE ratio would be for her. And again, this patient is kind of like patient number 3, so an infant. We know that for our child patients that 1 to 3 to 1 to 4 is appropriate, but since she is on the very low end of that child range, we can go with a 1 to 4 ratio for this patient. And then lastly, our 4-year-old male near drowning patient. Go ahead and pause the video and decide what an appropriate IDE ratio would be for him. And again, this is just a pretty straightforward pediatric patient, so an IDE of anywhere from 1 to 3 to 1 to 4 would be appropriate. Okay, so now we have gone through all of the settings, the settings on the ventilator that you really need to know. We've practiced several of them, and so now we're just going to practice the rest of them and kind of help put everything together here. So we're going to use our same 8 patients that we have been, but you don't have anywhere to write down your answers for this, so we're just going to kind of go through it together, and hopefully it makes sense by the end here. So our first patient is our 50-year-old male post-cardiac arrest. So we need to figure out his breath type, what mode we're going to put him in, what his pressure control would be if we're in pressure control breath type, what his pressure support will be if we're in SIMV mode, what PEEP we're going to start him out on, and then what FiO2 we're going to start out on. So let's just go through these kind of together and think about them yourself and see if you would have chosen the same things. So as far as breath type, we can use either volume control or pressure control. Either of them is perfectly adequate. Mode, we said that SIMV is probably our best mode choice for the pre-hospital and inter-facility transport environment, so we'll choose SIMV. Now, if we are in pressure control breath type, we're always going to start our patient on a pressure control of 15 centimeters of water. Pressure support wise, so if we're in SIMV mode, which we said we would be, we're going to choose a pressure support of 10 centimeters of water. We're always going to start with a PEEP of 5 centimeters of water and an FiO2 of 100% or 1.0. Alright, so then our second patient, our 81-year-old female CHF exacerbation. So hopefully you start kind of seeing a pattern here. Breath type wise, again, either pressure control or volume control would be perfectly appropriate for her. Mode, we're going to use SIMV, a pressure control of 15 centimeters of water, a pressure support of 10 centimeters of water, a PEEP of 5 centimeters of water, and an FiO2 of 100%. So patient 3, it's our 7-month-old female with foreign body aspiration. Now this will be a little bit different as far as breath type goes. So in our infants, remember we said with their small, fragile little lungs that we probably want to use a pressure control breath type, and especially if they're less than 10 kilos, and if I remember correctly, this patient was less than 10 kilos for her actual body weight. So Breath type, pressure control is going to be our best option for that. Mode is still going to be SIMV. Our pressure control is going to be 15 centimeters of water, our pressure support 10 centimeters of water, PEEP of 5 centimeters of water, and FiO2 of 100%. All right, patient number 4, our 7-year-old male with an asthma exacerbation. So we can use pressure control breath type or volume control. Either would be fine for him. Our mode is going to be SIMV, pressure control of 15 centimeters of water, pressure support of 10 centimeters of water, PEEP of 5 centimeters of water, and an FiO2 of 100%. All right, patient number 5, our 16-year-old male with pneumonia, and we can use either pressure control or volume control breath types. Our mode's still going to be SIMV. Our pressure control would be 15 centimeters of water, our pressure support 10 centimeters of water, PEEP 5 centimeters of water, and FiO2 100%. Patient number 6, 75-year-old female with COPD exacerbation. For our breath type, we can use pressure control or volume control. Our mode is going to be SIMV, our pressure control 15 centimeters of water, our pressure support 10 centimeters of water, PEEP 5 centimeters of water, and FiO2 of 100%. So patient number 7, our 4-month-old female with status epilepticus, and this is just like patient number 3, I believe, infant, less than 10 kilograms, so we definitely want to use pressure control as our breath type. Our mode is still going to be SIMV, pressure control of 15 centimeters of water, pressure support of 10 centimeters of water, PEEP of 5 centimeters of water, and an FiO2 of 100%. And then lastly, we have our 4-year-old male near drowning patient. And again, either breath type, volume control, or pressure control is perfectly appropriate. Our mode is going to be SIMV, our pressure control 15 centimeters of water, pressure support 10 centimeters of water, PEEP of 5 centimeters of water, and FiO2 of 100%. So this slide is just a summary of all the settings we've talked about in this section. Just to review those, the first setting that we look at when initiating a patient on mechanical ventilation is our breath type. So we're going to choose volume control or pressure control, VC or PC. Our mode in the pre-hospital and transport environment should almost exclusively be SIMV or synchronized intermittent mandatory ventilation. Our next step is to calculate our patient's ideal body weight, or we're going to use the actual body weight for infants. Next, we're going to calculate our patient's targeted minute ventilation. For adults, that's going to be 100 milliliters per kilogram per minute of ideal body weight. Pediatrics, 150 milliliters per kilogram per minute of ideal body weight, and infants, 200 milliliters per kilogram per minute of actual body weight. Next, we need to calculate our tidal volume, which for most of our patients is going to be 6 milliliters per kilogram of ideal body weight to start out with. The exception to that is our obstructive pathophysiology patients, so asthma, COPD exacerbation, etc. For them, we're going to use a starting tidal volume of 8 milliliters per kilogram of ideal body weight. If we're in pressure control breath type, we need to set a pressure control setting, and that's going to always be 15 centimeters of water to start with. Next, we need to calculate our respiratory rate, and to do that, we are going to divide our minute ventilation that we calculated by our tidal volume that we calculated, giving us our respiratory rate. If we're in SIMV mode, we need to set a pressure support, and that's always going to be 10 centimeters of water. And then for all of our patients, we're going to start out with a PEEP of 5 centimeters of water and an FiO2 of 100% or 1.0. And then lastly, we need to decide what the appropriate IDE ratio is for our patients, and then we can adjust that by changing the I time and or the respiratory rate. So for adults, the appropriate IDE ratio would be about 1 to 2. Pediatrics are going to be about 1 to 3 to 1 to 4, and then any patients with obstructive pathophysiology are going to be about 1 to 4 to 1 to 6. Now, all of this information can also be found on the initial ventilator settings reference. that you should have printed out, and you will be able to use that for your quiz as well as for the activity that we will start on the next slide. We are going to wrap up our initial mechanical ventilator settings section of the course by doing one last summary practice activity here. For this activity, you are going to need the second page of your initial mechanical ventilator settings practice document, and you can also have your initial mechanical ventilator settings reference document out and available to help you work through this. So in this activity, we have 4 patients. They are listed down the left side of this table. And then what you need to do is go through and fill out the ventilator settings for each of these 4 patients. So for each patient, you're going to pick which mode you would put them in. You are going to calculate their ideal body weight, calculate their minute ventilation, calculate their tidal volume. Now that's going to be their actual tidal volume. If you are in volume control breath type, it'll be their targeted tidal volume. If you're in pressure control breath type, if you are in pressure control breath type, what would their pressure control setting be? And regardless of whether you would actually put this patient in pressure control, I want you to go ahead and fill in, if you did put them in pressure control, what that pressure control setting would be that you would pick. And then decide what respiratory rate you would put each patient on, what their pressure support would be, what their PEEP setting would be, what their FiO2 would be, and what their IDE ratio would be. So go ahead and pause the video here, work through that table, get it all filled in, and then when you're done, you can go ahead and restart the video, and I will meet you on the next slide, and we'll talk about the answers and how we got them. Okay, so here are the correct settings for our 4 patients. Let's go through these real quick and talk about how we arrived at these settings. So first we have our 5'3" 42-year-old female with pulmonary embolism. So we talked about in our transport and pre-hospital environment that the ideal mode for us to use for most patients is going to be SIMV. So that's what we'll choose for this patient. Her ideal body weight, if we plug her height into our equation, comes out to 52.4 kilograms. And then if we multiply that by 100, we get 5,240 milliliters per minute, or 5.24 liters per minute for her minute ventilation. All right, so then for her tidal volume, either actual or targeted, doesn't matter, her ideal body weight of 52.4 kilograms times 6 for 6 milliliters per kilogram of ideal body weight comes out to 314 milliliters for our tidal volume. Now if we're in pressure control breath type, we would set her pressure control at 15 centimeters of water, as we do for everyone. Right, and then if we take her minute ventilation of 5,240 milliliters per minute divided by her tidal volume of 314 milliliters, we're going to get a respiratory rate of 17. All right, since we're in SIMV mode, our pressure support, we're always going to set that at 10 centimeters of water. Our PEEP, we're always going to start out at 5 centimeters of water. FiO2 of 100% or 1.0. And then for an adult, our IDE ratio, we're going to start at 1 to 2 because pulmonary embolism is not an obstructive pathophysiology, so our IDE should be 1 to 2. All right, our second patient, 6'1", 85-year-old male with COPD exacerbation. Again, we're going to use SIMV for our mode, and his ideal body weight calculates out to be 79.9 kilograms by using our formula. Again, for an adult, 100 milliliters per kilogram ideal body weight is their minute ventilation requirement. So 79.9 times 100 is going to be 7,990 milliliters per minute, or 7.99 liters per minute. Now our tidal volume for this patient, either actual or targeted, since COPD is, or a COPD exacerbation is an obstructive pathophysiology, we're going to need to multiply his ideal body weight times 8 instead of times 6 to get our tidal volume. So 79.9 kilograms times 8 milliliters per kilogram is going to give us 639 milliliters for his tidal volume. Again, pressure control of 15 centimeters of water. Now if we take his minute ventilation divided by his tidal volume, so 7,990 divided by 639, we're going to get a respiratory rate of 13 breaths per minute. Our pressure support is still going to be 10 centimeters of water, our PEEP 5 centimeters of water, our FiO2 100%, 1.0. Now, since he does have obstructive pathophysiology with that COPD exacerbation, we're going to give him a longer time to exhale by targeting an I to E ratio of 1 to 4 to 1 to 6. All right, our third patient is 3 foot 1 inch, 5-year-old female with COVID-19 ARDS. No change in mode, still going to use SIMV, and then using our formula for our pediatric patients. A 5-year-old pediatric patient will have an ideal body weight of 18 kilograms. Now here we're going to multiply 18 by 150 milliliters per kilogram to get our minute ventilation, because pediatrics are 150 milliliters per kilogram. So 18 times 150 is going to give us 2,700 milliliters per minute, or 2.7 liters per minute of minute ventilation. Our tidal volume, I'm going to take 18 kilograms multiplied by 6 milliliters per kilogram, giving us 108 milliliters for the tidal volume. Pressure control, going to be 15 centimeters of water again. And then if we take our minute ventilation of 2,700 divided by our tidal volume of 108, we're going to get a respiratory rate of 25 breaths per minute to start out with. Pressure support still going to be 10 centimeters of water, PEEP of 5 centimeters of water, FiO2 of 100%, 1.0. And then since this is a pediatric, they need a little bit longer time to exhale. So we'll use an I to E ratio between 1 to 3 and 1 to 4. And then lastly, we have our 5-month-old male with RSV bronchiolitis. This patient has an actual body weight of 7 kilograms. Still going to use SIMV for our mode. And then if you remember, for infants, so less than 1 year old, we're not going to calculate an ideal body weight. What we're going to use for their ideal body weight is just their actual body weight. So for this patient, 7 kilograms. For minute ventilation for infants, remember that's going to be 200 milliliters per minute. So 7 times 200 is going to give us 1,400 milliliters per minute, or 1.4 liters per minute for this patient's minute ventilation. Then our tidal volume for this patient, we will take 7 kilograms times 6 milliliters per kilogram. That's going to give us 42 milliliters for our targeted tidal volume. And that's important because we're going to specify that this patient, this is a targeted tidal volume, and that's because in our patients less than 10 kilos, remember we said we're going to only use pressure control breath type. So if we're in pressure control breath type, we don't set an actual tidal volume. We calculate a targeted tidal volume. So that's going to be 42 milliliters. And then for our pressure control, which we're going to be in, we're going to set that at 15 centimeters of water to start with. If we take our minute ventilation of 1,400 divided by our targeted tidal volume of 42 milliliters, then we will end up with a respiratory rate of 33 to start with. Our pressure support of 10 centimeters of water, PEEP of 5 centimeters of water, FiO2 of 100%, 1.0. And then for our younger pediatrics, our infants, go ahead and put them on an I to E ratio of 1 to 4. So if you are confused by any of this, then please go back and review this section of the course. Look at your reference documents. If that's still not helping, then please don't hesitate to reach out to a faculty member, and we will help you get this down, because this is vitally important to understand this stuff before we move on to the next section. But if you were able to get through this and fill in these settings without any difficulty accurately, then you can be confident that you've grasped this content and are ready to move on. Lastly, in this section, I just want to bring up this concept of cheat sheets, and this is something that I would recommend putting together when you start practicing on your own. Many of us carry these. They are extremely helpful, and it kind of takes the work off of your brain in what can be some stressful situations. So these are just some examples. Please don't copy these directly, but I would recommend making your own that work for you when you do begin practicing. And basically the idea behind them is that you can set them up several different ways. The way these specific ones are set up are for males, and then based on their height, this already has calculated for us what their ideal body weight is. If we're using a lung protective versus an obstructive strategy, what their minute ventilation target is, what their tidal volume is going to be, what their respiratory rate is going to be, and then what the rest of their settings are. So in stressful situations, this can take some work off your brain. The next table here is females, and it has the same information for adult females. And then we have one for pediatrics, and then one for infants. So these are very helpful, but I can't stress enough that you can't just rely on these. You have to know how we arrive at these values, and that should make sense to you in your head, where all these numbers come from. And if you don't have this in front of you, you should still be able to reason through and pick the appropriate ventilator settings for your patient. So that concludes section 2 of the ventilator physiology course on initial ventilator settings. And so we will see you for section 3 when you are ready.